Good evening. I'd like to call the Island Hospital Board of Commissioners together for a working board meeting this evening. And Vince, will you call the roll, please?
Thank you. Commissioner Lang?
Present.
Commissioner Bogosian?
Present.
Commissioner Mon?
Present.
Commissioner Iverson?
Present.
And Commissioner Ely is absent. I would like to just make an announcement that tonight's proceedings are being televised, and they'll be available on Channel 10 hopefully by 2 o'clock tomorrow, so we want to make sure we get this out quickly. As well, the slide deck that you'll see this evening will be available on our website, 0800 tomorrow morning. Thank you.
Thank you, Vince. And I'd like to welcome those community members and others to the meeting this evening. This is a meeting that we're going to discuss where we've come from and where we're going with respect to Island Hospital. And you know that the public is always invited to our board meetings. But this is a special kind of board meeting we're calling a working board meeting, where the commissioners are going to discuss what we see and hear this evening, and there will be no time for public comments. We've had open meetings at the board, and many of you have attended. We've had public meetings away from the board that many of you attended, and we welcomed you there. And a lot of you have spoken specifically about your concerns. And I want to tell you that all of us, all of the commissioners have listened to you very carefully. And not only listened to you, we've read a lot of material that you've sent us over the emails and in letters. Each of us have a fairly substantial pile of documents that you've told us how you feel, and that's good, because you understand that you're the stakeholders. You own this hospital, and we're beholden to you to make this hospital work and continue. And I also want to say that even after we discuss what we're going to do this evening, there'll be plenty of opportunity for other inputs from the citizens. This process is not going to take a week or 2 weeks. As we go through this process, it's going to take a considerable length of time, and during that time, you will be invited to come to our meetings, and also we'll have special times when you can make your own comments. But before we get to the agenda, I want to read you a statement that regarding the recent opinion from the Washington State Attorney General. And the statement goes as follows: "We have reviewed and performed a preliminary analysis of the recent Attorney General's opinion related to abortion and contraceptives services in public hospital districts. While we are continuing to review this opinion, we believe that Island Hospital currently provides services in a manner consistent with the Attorney General's opinion. Additionally, it has been and remains our goal that any affiliation-type transaction that Island Hospital may enter allows for the continuation of the services Island Hospital currently provides, and such affiliations shall fully comply with all applicable legal requirements." So as Vince indicated earlier when he called my name, I'm Paul Mon, and I'm one of 5 elected board members. And what we're going to be doing is the following. I'm going to take a little bit of time and summarize what has happened over the last year and a half, maybe as long as 2 years, when we've been looking at the issue of what to do with this hospital in terms of ensuring its survival. And then our consultant, ECG, will provide a graphic compilation of all the data that has been gathered through written materials, through oral materials, and other materials, so that you'll see what we're working with here. And during that time, our board will ask questions, we'll get input from ECG and others, and we will debate what we're hearing. And I've asked each of the board members to be prepared to ask any questions, and everything is on the table. I want you to know this is going to be an open discussion. So let me take you back a little ways. And as a matter of fact, in 2011, we began to hear a lot of things going on with health care. And you're aware of this. Big changes are in the wind, and many of them are occurring and have occurred. We're all aware of so-called Obamacare. The Affordable Care Act is going to impact us. Medicare has been reducing our rates for some time now, and as a matter of fact, we've been hit with a sequester to, I think it's a little over $50,000 a month they've taken away as a result of the sequester. So we're trying to adjust with those concerns. And of course, so many hospitals, small and large, even in our area, have merged, consolidated into major systems. And so the question is, how do we prepare for those changes? Yeah. Because what we want to do is ensure that our hospital and its core services, are here to meet the community needs. That's our job, and that's what we need to ensure. You know, we currently can meet our operating expenses of the hospital. But when we look ahead 5, 10, 15 years, it's going to be extremely difficult to accumulate enough cash to meet our capital needs and keep us at the state of the art that we are today and provide those high technology services that we do provide. Already, as a matter of fact, we've had to delay some major purchases because we just don't have sufficient capital in the bank. So during this several years that we've been talking about this, we've discussed our concerns with Skagit Hospital, the board and the administration of Skagit Hospital. And well before the 2011, when we really began to really gel on this thing, Cascade from Arlington came to us and said, can I join those discussions? And as a result of that, we found out that we all had similar concerns. We're all facing many of the same issues. And so what we decided to do was to draft what's called an interlocal agreement with Skagit and Cascade to try to jointly figure out what were our options. And so the goal of the interlocal was to seek a system partner that supports us in enhancing patient care access, quality, and efficiency in our region. The other thing we decided that we would try, and I say try, to select a system, the same system partner. All three of us would try to select the same systems partner at the same time. It's important to note that we jumped into this exercise to just explore what were the compelling reasons to do something to allay our concerns. We never agreed to do anything other than explore our options. And the options mean, if the three of us work together and decide what level of integration, that is, what level of involvement with a major system we wanted to do, we would have greater leverage, the three of us, to be able to negotiate something that would be more beneficial to us than if we did it by ourselves. The combination would give us greater leverage. And so to see what other larger systems offered, we began a project to understand the rationale for affiliation. And ECG will give us a lot more detail than I'm just going to touch on a couple of things I want you to hear. First of all, we prepared a request for indication of interest, some people call it RFI, sent out to 13 major systems, not only local but in the regional area and in some other states, asking them, would you be interested in this interlocal, an arrangement with this interlocal? We received 8 proposals or responses back from the RFOI that said, yes, we would like very much to talk more with you. And so ECG helped us prepare an RFP, which was sent out to the 8, from which we received 4 in return. And you know the 4, and rather than just discuss those, I'll let Matt talk about those. But so in April of this year, we received these responses, and what we have entered into since April is a most arduous exercise to understand what each of these suitors was offering. The proposals were, some of them were 4 to 5 inches thick, to see that responded to our request for proposals. And one of the things that came out during this was that the suitors, the four groups that responded to us, told us that they would not share private information with us unless it was held private. They would not give us the information we absolutely needed to have unless we held it private. And here's where a lot of this confusion has come in, because we needed this data, and the only way we could get it from our suitors was if it was held private. So and as you know, the only time that we can sit and talk in private is when our board, a minority of our board, comes together. That is, since we have 5 members on our board, only 2 of us can sit and talk together in private. Anytime 3, 4, or 5 of us together, it's got to be public. And we have been absolutely careful not to talk with more than 2 of us together. And as a part of that, Dr. Ely and myself were named into a joint board steering committee. Skagit nominated 3 people because they have 7 people on their board, and Cascade 2. And so we've had a large number of meetings with ECG and our administration to go over this material. And not only over this material, ECG helped us with oral presentations from the different hospitals and site visits. So you can see the amount of information we've been working with. But it was clear, the interesting thing, it was clear from the beginning that the 3 hospitals viewed the level of participation or the level of affiliation or the level of integration with any one of these systems considerably differently. Skagit viewed it differently, Cascade, and of course Island viewed it differently. Because integration means how softly or how lightly you want to deal with a hospital or how fully you want to deal with. And Matt will talk about exactly what I'm referring to here. So sort of bring this to conclusion on my part. In the last couple of months, 2 issues have popped up that just set us back on our heels. And these issues are associated with the ERD, the ethical and religious directives that have so many of you have commented on it and so forth, and And two of our hospitals, two of the three hospitals, and you'll find out why there's only three in a minute, are non-secular. So the ERDs are a component of that discussion. And the second issue was an antitrust issue that I just referred to in my opening statement, and the Attorney General has made some comments, and the Governor as well, in terms of what's going on there. So rather than push ahead, I know you're anxious and interested to see what it is that we've done and what the data looks like. So do any of you have any comments before I turn this over to Dan?
Not yet.
No, just the fact that the Joint Board Steering Committee has been working very hard to do this, and the rest of us are just waiting to hear what's going to be presented today also. So the other three of us are going to be hearing a lot of this information right along with you. And I wanted to make that very clear.
Well, it is,
it's been
because
difficult.
this information that you'll see on the screen, none of these three have seen it.
We've not seen this yet.
That's just how difficult this process has been. But you can appreciate that. Dan?
Matt.
Well, thank
Matt.
you. The purpose of this evening, as Paul has suggested, really is to an opportunity for the steering committee to report out on the very significant amount of work that has been undertaken over the last roughly 6 months, 6 to 7 months, starting in the early part of this year. And so what we're going to do this evening is go through a synopsis of really the high points of what has been learned throughout this process. The objective of this evening is as Paul suggested or indicated, is to educate the other members of the Board of Commissioners who have not been a part of the steering committee to date in preparation for the upcoming meeting next Thursday, at which time each of the three public hospital districts will be making decisions about how they will proceed in terms of the affiliation. So in terms of this evening's agenda, first we'll start out with a little bit of background, a synopsis of where we've been, what the process has looked like, really just an overview of that body of work. Then next we will sequentially step through the key elements of this process over the last several months. First we'll talk through the proposals that were submitted by the prospective partners, and we'll go through the evaluation that was completed by the steering committee, looking in great detail at those proposals. Next, we'll talk about the oral presentations by the prospective partners and the evaluation or the survey that was done following that. Then next, we have an overview or a recap of the site visits that the commissioners did with recent affiliation partners of each of the prospective organizations, as well as some other updates. Then next, we'll change gears, and throughout the process, we were asked numerous questions by the steering committee, and as a result, additional research was required. And so we'll report out on what we found in response to the questions raised by the steering committee. From there, then we'll turn to kind of wrap up. We'll go through a risk assessment, a body of work that was done to understand what are the implications of affiliating or not affiliating with these respective organizations. Compare the proposals and the affiliation opportunities with each of these organizations to the goals that were established at the forefront of the process. Then lastly, end with a series of additional considerations. And just as a reminder, you all are certainly welcome to stop and ask questions or chime in with additional comments as we go, but we will have, we'll pause as we go through and certainly take time to elicit your feedback.
Thank you.
So just to kick off, so this first slide here is intended to be a recap of the process. So starting off to the left-hand side of the page here, we initially began back in January of this year, and at that time we did a series of interviews and worked we actually met with all the board members and management team from each of the three hospitals to get consensus around what is the strategic direction, what were the goals for affiliation, what was the purpose, and really what were you all looking for in an affiliation relationship. That body of knowledge was then used to craft the request for proposal, which was submitted at that time to 5 organizations, local or regional health systems. Subsequent to that, a series of information was collected back in iterative review, analysis, additional follow-up questions, et cetera, with the prospective partners, giving the steering committee a time to get more information, become more well acquainted with the options, and to answer the questions they had about the process and the partners. Where we are today is this brown box, where we are now bringing back the information that's been collected throughout the process to the remainder of the board. And we are holding similar meetings yesterday, today, and tomorrow with all three of the boards of commissioners for the three hospitals. Then lastly, what will be forthcoming next week is recommendations coming forth and concluding with a vote by each of the boards around the selection of a partner. So in terms of the approach or the strategy around selecting a partner, functionally what we started with, again, as I mentioned, we initially submitted proposals to 5 organizations, Multicare, Virginia Mason, University of Washington, Peace Health, and Providence. Of those, Multicare responded indicating that they would not participate in the RFP process, so we're functionally left with 4 organizations participating. And so the strategy that the steering committee identified was to start out with evaluating these proposals and coming to consensus around a singular partner to affiliate with, recognizing that there are significant synergies among the 3 organizations and that finding a singular organization to align with would have the most benefit for your respective organizations. However, we also recognize that once that partner is selected, that there will be separate agreements and affiliation relationships struck with that partner. And so that's where you then see coming out at the end three affiliations resulting from the process. So at the beginning of our work, so again going back to the first part of this year, a series of goals were established. And really these were meant to codify the rationale for why enter into an affiliation relationship and what did we hope to achieve through such an affiliation. Functionally, the goals can be categorized into 3 major categories. First is to enhance clinical services. And from that, we looked at both the availability of services as well as an enhancement of quality of what is available. Secondly, promoting organizational sustainability. And from this perspective, really what we looked to was the financial stability and sustainability of the organization. Investment in clinical services, so being able to increase, add to clinical services, make investments, targeted investments in the organization. And then lastly, looking to recruitment and retention of physicians in the organization, recognizing that at the end of the day, your physician enterprise really is the engine that drives the hospital. Then finally, there was quite a bit of interest and attention given to thinking to the future. Where is healthcare reform going? What are the implications in creating a structure and having the infrastructure necessary to be poised to participate in this new environment? And so to that end, specifically we identified being able to gain access to a best-in-class IT platform and electronic health record, as well as access to new payment models, being able to participate in accountable care organizations, bundled payments, or other models that may come forward. So once the proposals went out and came back, functionally we received a range of options in each of these proposals. The majority of respondents included 3 different scenarios in their proposals, the exception being the University of Washington, who really had they had two proposals, both of which were on the low end of the affiliation spectrum. What we saw, so the arrow here on the slide is intended to convey conceptually the range of options that were articulated in the proposals, ranging from a low to a high integration. When you look at this, and again, so we've given these generic titles of clinical affiliation, shared services agreement, and full affiliation. What we see is ranging, starting from the left on the clinical affiliation, substantively, This is an arrangement where your organization would partner clinically with the partner. There would be ability to refer tertiary and quaternary patients to that organization. There would be some interoperability where data interchanges occur between your electronic record and theirs. Limited support services could be provided, but they would be at fair market value, which we'll talk later about what the implications of that mean. Then lastly, governance would be exclusively provided by your organization. No capital, no branding. At the other end of the spectrum, again, just for context, we saw the full affiliation option. Again, we saw that this included tertiary and quaternary care coordination. In the full integration scenario or the full affiliation, it did include integration of management structures with the partner. We also see financial integration. And of particular note, with the financial integration also comes the opportunity for capital investment in the organization. We also saw clinical consolidation as an opportunity, both among the three interlocals as well as with the partner. And so we'll talk at great length this evening about what that means and what some of the partners proposed around clinical consolidation and development of regional programs. We also see integrated information systems. So in the high affiliation option, all of the partners propose to bring their EMR to your hospital and implement it, providing a direct coordination across the region and with their health system. One point of note is when we get to this model, because of the tight integration, there is a trade-off, and that is the limited role of governance for this governing body. Substantively, the partner would be responsible for day-to-day operations and governance of the organization. We did include in the request for proposal a series of minimum expectations expressed in terms of reserve powers for you as the board, to include things such as appointment of CEO, discontinuation or change in services, change in the assets, sale of the building, et cetera. So there were a series of reserve powers, and they all agreed to those.
There were a whole, the two that you've talked about, and including the possible amendment, there's an infinite number of these integration possibilities. Is there not? And were the suitors interested in anything other than these three, or were there other options that were?
Yeah. So the slide here really is intended to express a range. What we issued a fairly generic request for proposal and asked the suitors to come back and kind of read our minds and propose an option that met our needs. We did, however, in that proposal express some key goals in terms of access to an EMR, development of clinical services, et cetera. That being said, it is absolutely a continuous range of options, and all of the partners expressed flexibility and willingness to work with the partners to construct a model and a level of integration that met your needs. At the same time, they all expressed their preferences in terms of if they were in the driver's seat, what they would like to see. And by and large, that was skewing towards the high affiliation option, if for no other reason than simplicity for them.
I think the one thing that I would mention is that they were amazingly consistent in the trade-offs of their various options, meaning at the low end, there would not be any capital, no branding, but you would also retain full control. At the high end, there would be capital investment, there would be IT, there would be branding, but the control would go to the suitors. So it was indistinguishable between the suitors, those trade-offs. They were all the same for all the suitors, except for the University of Washington, which only stayed on the low affiliation end, but they were consistent in those same trade-offs.
I do have one question, and I noticed that you mentioned no capital provided in the loosest and then the middle integration. And although no capital would be provided, did you explore or ask any questions as to ways to increase capital capacity, perhaps through loan guarantees, through maybe increased creditworthiness, so that because that appeared to be one of our goals, was to increase the capacity of capital if we needed it.
Yeah, absolutely. So in the low to moderate affiliation scenarios, because there is not a consolidation of the balance sheet, Island would not have the ability to draw on the credit or the capital wherewithal of the partner organization. What they all did speak to, again with great consistency, was their ability to improve your organization's ability to generate capital. We'll talk through this later, but it comes through cost containment, through revenue enhancement, expansion of services, et cetera, but ultimately driving to improving the bottom line and increasing your ability to generate cash.
Thank you.
So before we move on, the next section here is going to go through the proposal. Any other questions just in terms of background and kind of how we got this process going? Okay. So once the proposals were received, again, four sets of proposals or four suitors responded. Of those, 3 of the respondents had 3 different scenarios that they included. One of the respondents, University of Washington, had 2 scenarios. For each of those, there were 15 categories in the proposal. As a team working with the steering committee, we went through and evaluated all 12 options in 15 categories. So you can appreciate the level of detail and time that went into that process. For each of those categories, we used this 4-point scoring measure that's shown here on slide 6, ranging from below expectations to exceeding expectations for each of the criteria. What we're going to do on the next handful of slides is walk through and show you the actual results. And this is a composite of after iterative reviews with the steering committee, with the management team, et cetera, but the ultimate result that came out of it. One other point of note is that each of the categories in our 15 category section were also weighted in order to take into account the relative value or perceived value of that particular issue to the organizations. Because at the end of this, you'll see we come out with a composite score. The other last note here is that as we walk through this, these are all comparisons of the high affiliation option from their prospective partners, again, because there was significant interest among the steering committee of the high affiliation option as well as from the partners. So again, just for simplicity, this is what we're going to show. So as we look at the results, I'm going to key off of kind of the key points of distinction in the proposal. So first, in terms of strategic vision for the interlocals, Peace Health stood out. And the reason why they were ranked as a 4 was they spoke at great length in terms of their vision for developing new programs, clinical services, and really enhancing the clinical care in the region. And collectively, the steering committee was very impressed with their proposal. Next, as we looked at the category of healthcare reform and related strategies, and so this is really looking at the organization's preparedness and plans for, as well as infrastructure to participate in healthcare reform, new payment models, et cetera. As we contemplated Providence and Virginia Mason, we were collectively very impressed with what they had to offer in terms of the infrastructure, the work that they have underway today in terms of going directly to employers to contract. In the case of Providence, the infrastructure, the IT systems, and the personnel that they're putting in place to back up and support these initiatives. Lastly, in terms of local and regional services, Peace Health stood out. There was a very strong theme, and you'll hear us talk over and over throughout the evening about this issue in terms of local services as well as the strategic vision from Peace Health. Very much an interest in developing and expanding clinical services. There were, I believe, a dozen to 15 service lines that they talked about specifically in their proposal around enhancing, growing expertise, growing opportunity for the interlocals for these services. Ultimately, what their vision was by consolidating key services at the various hospitals, it would create an opportunity to have centers of excellence. And so a lot of perceived benefit. Next, moving on to slide 8 here. For support services, Peace Health and Providence scored the highest. Reason being is that both organizations have a regional support system. Both have consolidated back office functions. Providence has theirs in Renton, Peace Health theirs in Vancouver, Washington. Both had a robust and well-organized support service engine, so that's why they were scored highly. For information systems, when we looked at the details, Providence stood out significantly in terms of the infrastructure, their ability to implement, the current state of their implementation of EPIC. We'll get into this in much greater detail here in a little bit, but Providence really stood out in that category. Next, in terms of the financial resources and revenue enhancement, Peace Health stood out from that perspective. Again, twofold. One, in terms of the focus on building services in the region and therefore the intended benefits of generating new revenue in the area, as well as there was an express commitment or description around plans to invest capital in the region. And so that was the other thing that stood out for them. In terms of branding, Providence stood out because of they have actually proposed that the affiliation would come through Swedish, and there was perception of very strong branding benefits associated with Swedish, as well as the opportunity to bring that brand to bear immediately. Then lastly, in terms of the faith-based issues, we took that into consideration even from the outset. And Virginia Mason stood out because it is a fully secular organization. While both Peace Health and Providence have a secular arm to their organization, at the end of the day, the mothership, if you will, is a religiously affiliated organization. And so for that reason, we gave Virginia Mason the top score in that category. So you see here at the bottom of the page the resulting weighted average composite score for the three organizations. Point of note is that the University of Washington is not scored in this particular exercise because they did not include a high affiliation option. So in this particular example, what we see is that Providence and Virginia Mason stood out significantly with scores in the 78-73 range, and Peace Health, Peace Health and Virginia Mason stood out at the top, and then Providence several points down below in the 65 range. One other point of note, just as we walk through this evening, the four partners are organized alphabetically, so you'll see as we go through the evening, it's going to be Peace Health, Providence, Virginia Mason, and UW as we go.
Well, I think it should be noted also, Matt, that this was the first step in the process, and as it said on the bottom of that last slide, this was purely based off the information that we had in the proposal responses. Okay?
Mm-hmm.
So after the initial proposal was submitted, we received announcement or received word from Peace Health and University of Washington that they were entering into a strategic affiliation, strategic collaboration. And specifically what they spoke to were a number of benefits and a number of elements of that affiliation. First is that it creates a pipeline or a mechanism for referral for high-end complex patients to the University of Washington. Associated with that, there were a couple of supporting strategies that would really make it able for patients to easily access complex care, quaternary care from the University of Washington. First, is integration of the health records. So Peace Health and University of Washington will be developing data interchanges so that their health records can talk together. The implication is that information could be collected locally here in Anacortes for a patient, and then that same record would be available to specialists, subspecialists in Seattle, so that a patient would not have to tell their story twice, so that information, tests, exams could be performed locally and not have to be repeated when the patient went to Seattle to see that specialist. As well, they will also be developing a standard set of pathways. What that means is that patients, a subspecialist, say a cardiac surgeon or some such, could tell the referring physician, the cardiologist, what workup needed to be done for a patient. That information could be collected locally, and then again, when the patient went to Seattle, saw that specialist, the way that they received care, the information collected would be consistent with what that specialist was expecting. Again, making it more expeditious for patients to receive care, as well as reducing cost and burden for the patients. Next, they talked about the benefits of the teaching program and the ability to extend those benefits to Peace Health and then also to the interlocals. Implications there being opportunity to participate in teaching programs, residency programs, as well as the spin-off benefits in terms of residents coming out of those programs looking for jobs as it relates to physician recruitment. Next, they talked about branding and the opportunity to pull in University of Washington branding to service lines or categories in clinical services that are jointly worked on with the University of Washington. Then lastly, both organizations will be jointly collaborating in each other's ACOs. And so what that means is a very large ACO network spanning from Seattle northward that the interlocals would be able to participate in. As well, that ACO, as you think about going to employers and having a network of services to be able to offer them, having the University of Washington in that network that you're able to offer employees is certainly significant. Lastly, the last kind of key message that came through from the University of Washington and Peace Health at this time was the University of Washington communicated that their proposal in terms of the low and medium affiliation options stood as it were. And we actually went back at that time previous to that and had asked, is there a more higher level integration scenario that you can bring forth? And simply what they said is, if that's what you're looking for, Peace Health is your option, and we will be a pull-through benefit, if you will, in a Peace Health affiliation option. Because some of the interlocals had a strong interest in a high affiliation option, at that time, really the decision was made to consider Peace Health and the University of Washington as functionally as a conglomerate, if you will, or a joint option. So as we go forward from this point forward in the evening, we'll talk about Peace Health and the University of Washington together as a affiliation partner. Granted, it's two pieces to the puzzle, but University of Washington is not subsequently considered as an independent option.
Two questions, Matt. One, what is the status of any agreement they have? I mean, is that consummated? And secondly, what does the University of Washington do with the ERD?
So the status is they are anticipating that they will have their relationship finalized by the end of September. In terms of the ERDs, they are doing, going back to the first slide in terms of the spectrum, they are on what we would consider a low affiliation or a clinical services affiliation scenario. There is no financial integration, there is no governance integration, and as a result, the ethical and religious directives that Peace Health has do not apply to services within the University of Washington. Does that answer the question, or any other questions on the affiliation?
So there is this proverbial firewall between University of Washington and Peace Health with respect to any ERDs.
Right. Well, yeah. The ERDs relate to any services provided in Peace Health facilities or by Peace Health employed doctors. Okay? It's the same for Providence. The ERDs apply to any of their facilities and any of their employed doctors. The affiliation with the University of Washington does not employ University of Washington doctors, so they are where they were, and the University of Washington facilities remain University of Washington facilities. So in both cases, there's no transfer of ownership or employment, and therefore there's no ethical and religious directives application. The major reason they got together, the two major reasons are, I mean, clearly, just to shed some insight on this, is this accountable care network, their ability to access the contracts of employers such as Boeing, much strengthened by being together. Okay, that's reason number one. Number two is the ability to have this continuum of care, not only continuum of geography, but continuum of care that relates to primary care all the way through to quaternary care. And they don't intermingle those services as much as they are complementary to each other, which is why there's no interference on the ERD issue.
And isn't it UW does not have the primary care issue? That was part of
the reason. They do geographically. I mean, they don't have primary care up here, for instance.
Right.
Or up in Bellingham. So they do have primary care clinics around the greater Seattle area, but that's difficult if you're trying to access a Boeing contract, let's say, and Boeing is up in Everett. Where are they going to provide the primary care? So that's why you see these types of affiliations, and that's one of the reasons for it.
Just for educational purposes, I'm not so sure everybody in the audience understands the model of the ACO that the current legislation is forcing us to head to. And I think that's a very important thing to understand, you know, for members of the audience.
Sure, we could take a couple of minutes. The term ACO, maybe I'll turn this way. The term ACO is related, is a term coined by the feds around Medicare. And what Medicare basically said is we want to develop accountable care organizations that provide a more integrated level of care. And so we as a payer, if you will, an insurance company, are going to sponsor some pilot programs in which we're asking the providers to sign up as accountable care organizations. And we will contract with them, and we will try new things in this relationship. We'll try sharing risk around patients. We'll try bundling payments for certain services. And in essence, we'll try to do a lot more population health management around Medicare patients than we traditionally have done. So the term was coined just a few years ago by Medicare for this new sort of integrated care delivery model that they saw that they wanted to move toward. So it's become sort of a ubiquitous term across the industry to create partnerships among providers that then contract with any insurance company, or for that matter, an employer, to take on a different type of population health than is traditionally found in like a fee-for-service arrangement or a PPO arrangement. So, for instance, the Boeing contract is what Boeing wants to do is have providers that will better manage their patients' health. Okay, better look at maintenance things, better look at coordinating the handoffs from primary care to specialty care or from specialty care to quaternary care. So the ACO, in Boeing's term, is trying to do exactly what Medicare is doing, but if you're Boeing, you cover a huge geography, so you want to contract with someone who can cover the waterfront, and that's why you see in our region a lot of these partnerships develop. It's the same will be true for Regents or Primera or other large insurance companies that want to put these kinds of networks together. It's in its infancy, but that, I think, when Paul talked about the coming healthcare reform has sort of prompted these kinds of structural alliances in the marketplace, if you will. So that's a little primer on ACOs.
I apologize because I didn't introduce our expert ECG senior team, and the gentleman who's been speaking the last couple of minutes is Dan Merlino, and the podium expert is Matt Stern. So I'm sorry, gentlemen.
That's all right. No
I thought it was Mayor Maxwell.
Yeah. Pinch hitting for Mayor Maxwell.
Okay, you can proceed.
So before we move on, the next section is going to get into the oral presentations. Let me ask if there's other questions, or Paul, you who sat through and you know the evaluations of the proposals and so forth, other commentary that you'd like to add before we move on.
I think we're okay.
Okay. So the next step, after having received the proposals from the prospective suitors, the next step in the process was a series of oral presentations. And so for 2 days and many hours, the steering committee plus additional members of the management team from each of the organizations, as well as physicians from each of the organizations. I think in combination we had somewhere between 30 and 40 representatives in total, sat through 2 days of presentations from these suitors. At the conclusion of those presentations, we conducted a survey, an electronic polling survey, and we used a clicker mechanism where we didn't have to do show of hands, so it was very anonymous in the way that we did it, but yet we got real-time feedback from the audience. At the same time, we also captured that feedback and were able to report on it. And so what we asked the audience, these 40-some-odd people who participated, was to rate the prospective partners in again, a myriad of categories, 10 to 15 categories. And again, on a range of 1 to 4, ranging from below expectations to exceeding expectations. And so again, the purpose of this evaluation tool was really to guide a discussion among the participants, get feedback. Again, obviously a challenge with so many individuals in the room. As it says here at the bottom of the slide, the majority of responses average between an average 2 to 3, so kind of right in the middle. So as we go through this, we're going to speak more so to those responses or survey polls that were either below that range or above that range because they stood out the most significantly. So first, in terms of Peace Health, as we go through, you'll see that just in terms of sheer number, and magnitude, they scored the most favorably in the presentation. Key elements that stood out were one, first off, was capital investment. It was in the presentation where they made mention of capital being earmarked for the region and plans to make investment, specific investment in the region. Later on, I think we'll mention specifically, but it was $50 million was the number that they threw out at that time. In terms of the targeted investment for the region. As well, and in conjunction, the strategic vision that they had. Again, this is coming back to the notion of development of regional centers of excellence, regional programs, clinical integration, clinical consolidation, as well the congruence of their vision for your districts and your region and care for your residents in alignment with yours. We talked about the regional coordination piece, critical services, again, that falls in that same category in terms of maintaining and ensuring access to critical services in the region. again, it goes down through here, the affiliation expertise, IT systems, support services, et cetera, their infrastructure that they had. Next, the Providence was the next organization. The elements that stood out most significantly for them, I think that the key theme coming out of the presentation from Providence was everyone was I think impressed, or it was impressed upon the audience, the infrastructure and the size and the organization of Providence. And so where they scored most significant or most favorably when they were in the areas of support services, information technology, and readiness for health reform. The participants understood the level of sophistication, the level of investment in each of these areas, and realized that it would be very easy, if you will, to plug into the Providence organization and the horsepower in those areas to support the interlocals. At the same time, the flip side to that same coin in terms of size and organization is size, right? So this big behemoth was also perceived to not be as good of a cultural fit to smaller regional interlocal hospitals. As well, there was some information in the session that indicated a orientation towards using the interlocals more so as a pipeline into existing facilities and services that Providence already has, and taking care out of the community. And so that was a real concern, and so that's where you see at the bottom of the slide why they scored especially low in that category. For Virginia Mason, again, the key areas that stood out, not surprisingly, top of the list was quality. Virginia Mason is known nationally and internationally for their efforts in quality improvement and value-based care. And so that was virtually a unanimous for Virginia Mason. Next, the congruence of vision, their interest in the region, talking about focus on services, this value-based element. There was a sense of that they thought and they had a similar perspective to the organizations. And then lastly, the strategic vision and cultural fit, there was also perceived to be a good alignment and match with Virginia Mason based on the information presented there. I think the last thing that point bears pointing out, though it's not below a 2, at the bottom of the slide, we do see that the revenue enhancement and the affiliation experience were both very low. Virginia Mason has limited, if any, health system affiliation experience. While in the past they have had a number of physician practices that they acquired and some they've divested of throughout the region, they have not partnered with in a fully integrated form another hospital or health system. We'll talk about their experience with Evergreen, which is on a much lower level of integration. But that was the reason why that was scored low. And the revenue enhancement in terms of their focus on growing and building new services locally was not as significant as Peace Health. So let me, again, pause here and ask for questions, or for those who participated in the orals, if there was other comments that you'd like to interject.
Matt, would you mind mentioning who participated again? How many people were in this survey and how it was done and where it was done?
So there
Clarify that.
Yeah, there were approximately, I would say, 40 individuals combined from the organization, so 10 to 15 from each hospital. That included 2 or 3 commissioners, the steering committee commissioners. Then there were approximately, depending on the organization, I would say 5 to 7 members of the management team, of the senior leadership team, and then somewhere between 3 to 5 physicians from each organization. So that was the complement of who. It was a 2-day event down at the Tulalip Casino.
Thank you.
Okay. So the next step in our process was to hold a series of site visits. Specifically, the steering committee wanted to understand more about what is it really like to work with and to partner with these organizations. And specifically to talk to another organization that had recently joined or gone through the partnership experience, seeking to understand, from the perspective of promises made, promises kept, cultural integration, and so forth. And so we'll kind of walk through here what we heard in those site visits. So the first was Swedish Edmunds, and so previously Stevens Hospital. Also of note, so I'll give just kind of a quick recap of what they did. So Stevens was another public district hospital. They joined Swedish when it was just Swedish. And the structure that they entered into was one where functionally they leased the hospital to Swedish. They stepped out of the business of managing and overseeing hospital operations. They then became functionally a landlord for the building, and on the side, the public hospital district now functions really more in the role of a charity or an endowment, sponsoring other health initiatives for the community. So from a cultural perspective, what we heard from the individuals from Swedish Edmunds was that they viewed their relationship and they viewed themselves as being a part of Swedish and not as a part of Providence. And that was pervasive throughout the organization. Next, in terms of the clinical impact, there were a lot of questions around, again, stemming to the religious concerns, religious issues. What we heard from Stevens or Swedish Edmunds was that they had not experienced any implications in terms of changes in clinical practices or services as a result of Swedish joining Providence. Again, keeping in mind that Swedish came in through a secular affiliation model with Providence.
Excuse me, Matt, did they offer the ERDs, legal abortion? Did they do that in their practice?
So they,
at that time when they joined with
substantively,
Swedish?
those services were not performed at their hospital.
At their hospital. So
it
ERDs
was a non-issue for them.
Yeah, non-issue with ERDs. Okay, thank you.
And they were not participating in death with dignity. So again, that was a non-issue for them. In terms of the governance as represented here, I think that the takeaway was, substantively, the board had a very different role. They were no longer responsible for overseeing clinical operation of the hospital. For them, that was just fine. They got what they wanted in terms of ensuring the ongoing operations of the hospital. They got significant financial investment in their organization, so they were pleased with that arrangement. Next, we went to Evergreen Health in Kirkland, Washington, and they recently entered into what I'll call a clinical services affiliation with Virginia Mason. What this relationship is really they are working together to learn from Virginia Mason in terms of the lean production model, and they are starting to collaborate in select services, so around neurology and cardiology services. Really what that has meant so far is starting to develop referral relationships. It's bringing subspecialists from Virginia Mason out to Kirkland. They're sharing information. Their management teams are starting to work together, again, from a knowledge transfer perspective. But there is not financial integration. There is not governance integration. There is no, if you will, glue contractually holding that together.
So the Virginia Mason relationship with Evergreen is way down at the bottom of the integration. Is that?
That's correct.
And is my understanding that they're not interested at all in re-offering that lower opportunity to the interlocals? Or have we investigated that, or where are we with respect to not having full integration versus what the Evergreen?
Yeah, so Virginia Mason included in their proposal 3 options: a very low, one that looked similar to the Evergreen model, and then 2 at the high end of the spectrum. They were very explicit in their proposal that they strongly preferred the high integration options, but there was at least a preliminary description of what that low clinical services affiliation might look like.
They've also been pretty clear that they'd like to move the Evergreen relationship up that continuum.
Right.
So I think if they were to go with a lower level of affiliation with the interlocals, if they chose to do that, they'd also want to move that up over time.
Culturally, VM is probably closer than any of these, in my opinion. And I don't know how many of you understand, but they conduct their business under the Toyota model. I mean, it's extremely efficient and works well. And I think if we were to join that, the VM situation, it's my way or the highway. I guess I'm overstating the issue, but if
not too much,
you go their way because it works, and that's what you'd be buying into, and there's some real advantages to that, but it changes a lot as to how we go about doing our business today here. Would you agree to that?
Absolutely. They are. So at one point in the process, we had an opportunity to meet with Gary Kaplan, who is the president and CEO of Virginia Mason. One of the things that he shared about is they have a statement that basically outlines who they are, what they do, their principles, their orientation around this production system. Every new employee is required to sign that, and some opt out at that point, that is not for them. As well, we heard that when they endeavored on this journey to take on this lean production model, there were quite a few physicians who left, and certainly we saw that in the market living in Seattle. Many physicians who came out of VM at that time because it was not a cultural match.
Having said that, great organizations have to have discipline, standards, predictability, and they have that. And that's one of the reasons they've become internationally acclaimed for their quality. So, they do not want to compromise on those standards and expectations because they know that's what makes them great. So it's a trade-off, as you say. You're gonna have a period of acclimation that could be, difficult, but it depends on how much you want to be part of that kind of a system and culture.
So I'm sorry. So do we actually have a list of what our wants and needs are and another list stating what we will not let go of?
In terms of services, or what do you?
Yeah, services, just all kinds of things. Do we have any kind of list saying that, for instance, we are not going to limit any services that we have? We are not going to do anything differently than the way we're doing it now?
Well, we've talked about that with each of the suitors, and to be perfectly honest, each of them has said, well, I don't know if that's prudent, because if we're going to be better together, things have to change. That's, I think, was a common refrain from all of them. So I wouldn't put that on any one of them. There certainly was a difference in how they approached service development and what services they wanted to focus on. I think, as Matt said, Peace Health had more of a specific plan for how to develop services. Virginia Mason said that they certainly wanted to put more primary care clinics within the region than there are today, and they said that they wanted to bring more of their specialists and specialty services to rotate through. Specificity around, oncology versus cardiology versus whatever was not provided by VM. There was not specific talk, as you might expect, for many of them saying, hey, we're going to pull these services out of here. But there certainly was no commitment that they, wouldn't move things around or consolidate things to create a different service delivery framework. All of them said, just to finish this off, that they would certainly have core services that are provided in the community, which is, I think, the phrase you used, Paul. All the core services would remain. And core services typically means, primary care, specialty care that relates to general surgery and sort of general services, and then you get into tertiary and quaternary care, which starts to be those things that you start to talk about moving and consolidating.
Mm-hmm. One of the things people may not realize is that Virginia Mason does not have all the bells and whistles, and what I mean by that is their depth and breadth of clinical expertise is lacking in a lot of areas. Whereas, for example, the university has almost everything. Swedish Providence has almost everything. So I think that's a consideration also. And just as an example, and I think we all know this in the audience, if you have a major burn, you're going to Harborview no matter what system you're in. I mean, that's, these things are going to be standard. Yeah. And no matter how we go forward, our goals have always been to provide the best care we can possibly provide to members of our community. And that's always been, I think, at least for me, I call it the my mother rule. Where do I want to send my mother? Assuming I like my mother, which I do. Or my sister or my daughter or whatever. But, and I think that should be understood that has always been at the top of our agenda.
So what we heard in the meeting with Evergreen was two things. One, in terms of their interest, we heard from Evergreen that they had an interest in this affiliation opportunity as it relates to the benefits of flushing out and rounding out the network that they and Virginia Mason are developing. Lastly, I think we talked to quite a bit about the substance and the structure of the affiliation relationship. Turning the slide here, slide 15, in terms of, so the next one is Peace Health and Southwest Washington Medical Center. So Southwest joined Peace Health, I believe, 2010, 2012. And just to give a little context, at the time, Southwest was in a fairly distressed position. They are, being in Vancouver, Washington, really the northern suburb to Portland, which has been a very competitive marketplace, and of recent, there's been some dynamics in that market, particularly with Kaiser moving volume around and so forth, which have really created some chaos. And so they were in a position where they really needed help. And so they fully integrated with Peace Health at that time. In terms of governance, so again, they were not a public hospital district. They were a standalone independent community hospital. Their board substantively became, the hospital board substantively became the community board. And as well, then members of the community board sit on this network or regional board. And just to step back for context, in the Peace Health vernacular, there's really a three-tier structure to their governing body. They have a system board, then a regional board, which is over several hospitals that are in geographic proximity, and then finally a community board. And the community board is local individuals who sit on that board. They have oversight generally for that hospital. But key decisions in terms of capital, strategic planning, et cetera, those types of issues are largely done at the regional level. And the system is driving overall system direction and so forth. So what we heard from Southwest was they were pleased that they continue to have a role in governance of their organization, and especially so that they now had seats on this regional board. And there were, the way that this model works, two individuals from the community board sit on the regional board, so they had a meaningful role in that. Next, in terms of the affiliation rationale, in terms of why Southwest went into affiliation, we talked about kind of the chaos in the market. I think one of the key things that came out that we heard very significantly from them is that they did not believe that they were big enough or strong enough to prevail and to stand on their own going forward. And I think it's interesting to note, just from a pure financial perspective, that Virginia Mason and Southwest Washington are within a few $1 million of each other from a revenue perspective. So similar size organization to Virginia Mason was looking at the tea leaves and saying, we're not big enough. Then lastly, around the religious issues, again, for them, given what they were doing currently in their organization, they did not experience any changes to existing policies. So the ethical religious directives for them were really a non-issue. The next thing that happened when we met with Peace Health at this visit was they brought...
I think we better clarify that a little bit, and that is because they didn't do death with dignity and elective abortions.
Mm-hmm. They didn't do it anyway.
Yeah, they didn't do it anyway,
Right.
but it doesn't mean that the relationship, that if somebody wanted to do it in their
Correct.
hospital, they could not.
Correct.
I think so that's a little confusing. That they can't, but they don't.
They didn't, and now they can't.
Right.
Let me interrupt you here for a minute. It's 6:20, and how are we going to get the information to you and the community in a time?
In a timely manner.
Is this how much longer do you think it's going to take to go through these charts?
We're seeing a lot of yawning, Matt.
We're seeing the
So you're saying speed it up?
we're seeing the audience clear out. We would like to have as many people from our community here to help us and not respond verbally, but by email, hopefully afterward, and what we're doing. And it's a bit redundant, but at the same time, I understand the need. But is there a way we can do it more quickly and still accomplish the same thing?
We'll leave it up to you.
Yeah, we'll move it along.
Okay.
But I think we're talking about a good 45 minutes to an hour to be
Total?
left to be done. Yeah.
Okay.
Or just Matt's part?
Because we're on page
Total.
we're on page 15. We got to get to page 40 something.
Yeah.
Okay.
We'll get there.
All right.
Have to be done after page 40.
Okay, so the next piece that came up was a updated proposal. Basically, Peace Health responded to really what they heard in the community forum in terms of some of the concerns around the ethical religious directives. And so what they brought forth was a new high affiliation option. And in this option, really what it's comprised of is a series of joint ventures. Joint ventures around clinical services as well as other support services. Key points of distinction in this new model compared to what they had previously proposed in their high affiliation options is that first, the district would retain control of the district and of the hospital in any services that were not included in joint ventures. Second, staff and physicians would remain employees of the hospital. Next, the support services could be provided through joint ventures, and the key issue or consideration there is that gives the ability to access these services on an at-cost basis rather than based on fair market value. The implication is that services that could be significantly a lower cost option than paying fair market value. Then lastly, the Statement of Common Values, the point of distinction here is that their Statement of Common Values, which is their interpretation of the ethical and religious directives, would apply only to those clinical services that were joint ventured with Peace Health. So, in other words, you might have while you have a whole totality of services, only those areas that you enter into joint ventures would those ethical and religious directives apply.
And I need to quickly interject that this is their proposal. It's not a done deal. It's just what they proposed around how this would be structured. and what they proposed around where the statement of ethical or statement of common values would apply. So, not an approved negotiated item.
And there was no specificity or is no specificity at this time in terms of what support services, what clinical services, how comprehensive is this, et cetera. So there's, to the extent to which the interlocals choose to move in this direction, there's a lot of work left to be done to define what such an affiliation would look like.
However, there were two things they said very specifically. One, they would still commit the capital, and one, they would provide the EPIC electronic health record system to the interlocal that went for this option to the extent they could, which is 85% of the total cost. So that's what makes it different than, say, a low affiliation option, is it's got a lot of capital behind it.
And the cost of a system like this, we're talking $10, $12, $15 million to install and operate.
Isn't that low?
I mean,
I think we're talking that for your hospital. For the interlocals, it's a, you can triple that number.
Yeah.
Yeah, I was talking about this.
Yeah.
So next, in terms of the last piece of the update here, we had a combined board meeting. I think most of you were there a couple weeks ago. During that time, there was a period of comments and questions from the community. Substantively, kind of standing back and observing, we saw two categories. One were issues and concerns around faith-based care, vocal opposition to partnership with a faith-based organization. And while partners addressed or appeared to address many of the specific concerns as listed here, there still remains an overall concern about that type of affiliation. At the same time, there appeared to be roughly a similar sized contingent in the audience that really was there to compel the commissioners to do what is best for Island Hospital or each of your hospitals, regardless of political or other concerns. So with that being said, I'm going to turn it over to Dan to go through the additional research and so forth.
See, this will go more quickly because he doesn't interrupt me as much as I interrupt him. So. All right, the additional research, we talked about IT and an assessment of what each potential partner brought to the table. We talked about their financial capabilities in terms of their current assets and ratios, and then financial projections related to what synergies there were financially in moving forward. But first, the IT assessment was done by MINS, which is a consortium that deals with IT issues. They looked at this, and basically the summary was that Providence was by far most ready to provide the system. It is burned in. It's been used in their overall system now for a few years, and that they could get it done faster, and they have procedures and processes to do it. Virginia Mason was viewed as having a well-accepted platform, but not a best-in-class platform. The EPIC platform is viewed as best-in-class. Cerner has had some difficulties with meeting meaningful use requirements, but they have applied it to themselves, to VM, in a very specific way, and they definitely know how to utilize that system to its full capacity. So they were viewed favorably, although not with a best-in-class platform. Peace Health was somebody who's making a transition to EPIC, same system Prov has, but that transition is going to take a while. And so MINS was a little bit nervous about how quickly that could be implemented, because they're just starting their ambulatory implementation, and thereafter they will do their inpatient implementation. So this is probably a process that is going to take overall 5 years, and they have talked about beginning implementation with the interlocals in 2016. So it has more of a delay than the other systems do.
Not to interrupt you, but you glanced over meaningful use. Tell the audience we are mandated by the federal government to make certain strides with information technology, and would you educate them?
Right. A system has to pass certain levels of what they call meaningful use, especially as it relates to the electronic health record, and the federal government has a certain criteria for passing that. And right now, frankly, the Cerner system has to come up a step to meet meaningful use criteria to get accepted, if you will, or certified as a meaningful use system. I think they're making the strides, but they're behind right now. Okay.
Maybe, Vince, would you like to make a brief comment on where we stand on meaningful use for our system, because we're farther advanced than any of these other organizations?
Thank you, Commissioner Iverson. I'm very happy to tell the audience that we've been on the Meditech platform since 1992, which is really very well advanced for the time. And today we've not only met meaningful use in the first year and received our $1 million+ payment from the government, but we are now poised to meet meaningful use stage 2 during the attestation period starting in October. So in November we will receive another $1 million from the federal government. So at this point, while IT is extremely important, we continue to meet the hurdles that the government has put before us with a system that, while again not state-of-the-art, clearly is a very stable, easy to maintain platform that is very economical, and one that's in over 3,500 hospitals in the United States. So while this is very important information, I think the community needs to understand that we are in a very, very good position where we stand right now. The future, it's going to be an interesting one, but the good news is we are really well ahead of our colleagues, as well as some of the big players that you see up there.
You can imagine the bookkeeping at the hospital when the government gives us meaningful use dollars and then takes it away with sequester.
Yes.
And then they give us some more and then they take it away. So you can know it's not a net zero value. It's the nature of this game in terms of this.
Unfortunately.
Thank you, Vince.
All right. So the second thing we looked at was a financial summary of the partners, and just as a precursor to talking specifically about their financial positions, some of the transactions that have applied to them in the last couple of years, you can see in front of you. Southwest affiliation in 2010. That's when they acquired Southwest Washington Medical Center, which is a 400-plus bed hospital. That increased the size of the business, but it did negatively impact some of their metrics, meaning their ratios, their days on hand, that kind of thing. Swedish affiliation in February 2012, they affiliated with Providence, and that totally integrated the two systems and frankly improved the financial wherewithal of Swedish. And the tower that Providence Regional has built in Everett is $460 million. It's a 12-story medical tower. Tower meaning an inpatient tower. Just be clear and specific about that for medicine patients, not surgical. Okay. Jones Pavilion, VM opened the Jones Pavilion, which is, as it says here, 250,000 square feet. That does include 7 floors of patient care space, et cetera, et cetera. On its downtown campus, they have a second phase that is slated for 2014. Okay, so that's what they've been doing. In that environment, their metrics as of 2012 were that, as you can see, Providence is the big player here. They have, as you know, hospitals up and down all the way to California and across the mountains over into Montana. So they have a wide berth, and they have $10 billion plus of net operating revenues. Meanwhile, Peace Health is at about $2 billion, and VM is at just under $1 billion. Their operating margins, VM runs a tight ship. Their operating margin is 3%. That's laudable. Their EBITDA, or earnings before interest, depreciation, and amortization, which is what that means. You can see the relative earnings. And the bigger, because of their scale, is Providence. The EBITDA margins are all pretty strong at 9 to 10%. The cash and cash equivalents, this is important, at about $450 million for Peace Health, about 1.1 or 2 billion for Prov Swedish, and about 81 million for Virginia Mason. The cash flow to debt ratio, is also very important. The higher, the better. And obviously, Providence Swedish cash flow is very, very good. The current ratio, that's your current dollars to your current debt, is the best is Peace Health. They've managed their debt well. They have good cash flow is what that means. They also have a better average age of plant. Their facilities are newer than either Providence or Virginia Mason. As we know, Virginia Mason is in the midst of building those new towers, but they have a fairly old plant as far as their hospital downtown, and that's why they're going through that transformation. Days in AR, days in accounts receivable, that's how outstanding your bills are to your patients. The low is better, and VM's is best at 38 days, which is good. Anything around 40 is very, very good. Their capital expense ratio, again, this is the ratio of your expenses related to capital, and higher is better. So 8%, Peace Health is the best in that score. So they each have, as you can see, their relative financial strengths. On scale, Prov Swedish is much bigger on certain metrics, operating metrics. VM is better on certain debt metrics. Peace Health is better.
Vince, would you tell us how much our net operating revenue is for Island?
Our net operating revenue is around $68 million.
Okay. Any other questions related to this?
Any questions?
Their financial position? Okay. In looking at financial projections, this is what could the interlocals, and most specifically in this forum, what could Island see to realize out of a partnership with these different institutions? Okay. First, the annual estimated financial impact for a low integration option for Peace Health would be about $2 million, Providence about $2 million, and Virginia Mason $600,000. This is synergies related to contracting rates, to revenue enhancement opportunities, to reduction of your cost structure, all those things taken into play. And one of the things you're seeing here, and you can see it for both the low integration and the proposed integration, because they all proposed a higher level of integration. But what you're seeing here is the fact that the scale of both Peace Health and Providence Swedish play into providing a stronger financial potential. Okay. In the case of Providence, it really does have a lot to do with their scale, which relates to both their infrastructure and cost and their contracting capability. Peace Health, very strong in its contracting capability, and the other thing that they're strongest in is revenue enhancement of services. VM is somewhat limited in both. That's why you see the difference. Any questions on that? Because this is a very important slide. It's very short.
It's a little confusing in the sense that if we, for example, choose a low integration with, say, Peace Health, $2 million, they're not going to bring us $2 million in a bucket. Basically, first of all, it's going to be spread over years, and secondly, that part of that's going to be because we're going to be made more efficient and somewhat more, it's really not cash.
No.
No, it's not cash. And in the case of the low integration, it's some coordination and synergies related to service delivery, service development,
Right.
Purchasing
and
power,
some
purchasing
on
issues.
and some on the coordination of support services like purchase services, taking advantage of their purchasing power,
Being able to
being
buy
part of their purchasing contracts. I can tell you, because we looked at them, would save you guys a lot of money.
Yeah.
So that's an example of even things you could do at the low integration level. When you get to the higher integration level and you can contract together as one organization, or you can further develop services, or they can provide more capital to develop your IT or your infrastructure, that's when the bigger bucks start to occur.
Could we get those sorts of services through a joint venture, or would we have to get into affiliated relationship, or you understand my question?
Yeah, a joint venture, which is it's a tight integration on a specific scale. So you could say, let's just make it up. Okay, you could joint venture oncology services, let's say, right? In that particular joint venture, you could have investment into that service that was coming from the partner, okay, without worrying about fair market values and all that kind of thing, because you are in a business together, okay? So it is tightly integrated, but just around that one service. So could you get the benefits? Yes, you could get the benefits of capital funding and probably more investment to increase the size of that service than you would in a low integration option, because in a low integration option, you would have to essentially fund the expansion of that service mostly yourself. So, but obviously, to finish off the answer to that question, you know, if you're just integrating around one service, you're not going to get the big benefit of an integrated relationship across all services.
And just to clarify, these are annual numbers, and so this is certainly there would take some time for the benefit to accrue. There'll be some ramp up, but these are annual figures in terms of enhancement to the hospital's bottom line.
Yeah, and the predominant number is on the low integration is the purchasing. Okay. Capital capacity, and this is another slide that speaks to their current capabilities. PeaceHealth has, when you look at the combination of their cash and current investments and board-designated funds designated for capital acquisition or improvements, they have close to $1 billion. Providence Swedish, I should say, has about close to $5 billion, $4.7 billion. This is available cash for investment. And then Virginia Mason has about $225 million in available cash. Okay? Their earnings before interest, depreciation, taxes, and amortization are about $204 million for PeaceHealth, $909 million for Prov Swedish, and $74 million for Virginia Mason. Again, along the scale, you can see the differences of scale all along here. Days cash on hand is a very important stat of just how much available operating cash you have, and that's 161 days for PeaceHealth, 176 for Providence Swedish, and 94 for VM. Finally, bond rating. The bond rating of PeaceHealth is A+, Prov Swedish at AA2, and Virginia Mason at Baa2. In sort of common nomenclature, Prov has the highest, PeaceHealth has the second highest, and Virginia Mason has the third. That you can see down below, the difference in the credit rating is equivalent to more than a full percentage point difference in interest rates between Virginia Mason and PeaceHealth, and it's about 1.5 between VM and Providence. So if you're borrowing money, that means that on a 30-year, $100 million loan, it's an additional $16 to $24 million in interest. So this is germane and this is what we were asked to comment on, but essentially PROV is in a very, very strong financial position. Peace Health has protected their bond rating, and they're in a good, strong position because they've got a lot of cash. And Virginia Mason, being a smaller scaled institution, does not have the cash and does not have the bond rating. So that's just sort of the facts of the lay of the land. Questions on that? Comments?
And Commissioner Mon, if I can just give you quickly the island perspective on this. Does this cash and current investments include their days in AR?
No, it does not include
so it's just,
AR.
So ours is about $19 million. The board designates about $3 million for capital acquisition. Our EBITDA is about $3 million. We're at 90 days of cash on hand, and our bond rating is A1.
Okay, risk assessment. So given everything we've said, quickly, the risk assessment for Peace Health is one on IT. I talked about how it could be slower than anticipated. We did get them to stipulate that they would be responsible for any increase in costs in that effort. Their likelihood is a medium likelihood. But we know it's going to be slow in the first place, and this is the risk that it could be slower than what is planned. The affiliation with PH and UW, we talked about that. When's it going to occur? It's supposed to be finalized by the end of September. To talk to the parties, they both say that they have an agreement in place. It's going through final review, but so the likelihood's fairly low. But if they fail to develop that agreement, the risk is that we've got a problem in accessing that full continuum, and some of those benefits around teaching and residency programs and some super specialists go away in that particular case. And then the religious concerns, certainly for Peace Health, we have community concerns. We know that related to faith-based organizations, and they're partially mitigated through the secular structure. They're certainly addressed more strongly through the recent proposal of Peace Health, but they are there, and we need to acknowledge that that's a medium to high risk. They have said that they would cover the legal costs related to this issue. That is not something that's in a legal agreement. That is just something that they have proposed, that they would cover legal costs if there were some related to that issue. So those are the three items related to Peace Health. When you move on to Providence and Swedish, it's interesting. We just talked about the fact that they have the most capital to allocate, but they were not forthcoming in their willingness to allocate that capital. And so the risk is that they would stipulate that the capital had to be essentially produced out of your bottom lines and therefore generated locally. The second is that they are a huge system with a lot of different hospitals and regions pulling on their coat. So the issue that capital would be scarce or be given to somebody else is a high concern. Volume moved to Providence Everett. They just built a new tower. It's 12 stories. The likelihood of moving some things there we thought was at least at a medium level, and that impacted what we were talking about with regard to provision of services and frankly, enhancement of services locally. That was the concern. And then finally, religious concerns. I already talked about that with regard to Peace Health. It's the same concerns with regard to Prov Swedish. Virginia Mason. The thing we have not mentioned is that if Prov Swedish and Peace Health are not selected, they will both create a competitive response. I think we're pretty clear on that. They're the only two that have adjunct services to the interlocals geographically. So that is a real concern. We consider that a high concern, that they would, one or both of them would take competitive actions against the three communities of the interlocals. High-value contracting.
Competitive actions means that they could come in and put a clinic
They could put a clinic, they could put an imaging center, they could put a surgery center. It would, you know, they're not going to put a hospital next door to yours. That's just not economical. But they could certainly put procedural centers and a variety of primary and specialty clinics. That's what we would expect to happen with, you know, with these two competitors. High-value contracting. VM has kind of bet the farm on the idea that the market is going to go, the healthcare world is going to go to population health management, to care coordination, and that's how things are going to be paid. They're also betting the farm that they are going to be very attractive to employers. Right now, it's impossible to say whether that, you know, the market's going to completely go that way or partially go that way or what. So it's a medium concern. The other concern is that they do not have a network as of yet. They don't have the breadth that a PROV has. They don't have the breadth that some of the other players have. That's, as I said, the Peace Health UW thing was created to get that breadth. So VM has to have partners. Capital, we talked about VM having thin capital, and do they have the capital to execute on the interlocal's capital needs? That one is a high risk, high concern, let's say, because taking debt would be difficult for them. It would probably change their bond rating. That's what their bond report said. So, you know, we would expect that they would want to generate new capital based coming out of the regions, like I said with Swedish, that they would see most of the capital for your area generated from your area. And finally, IT. This is an epic area. This is an epic region, north of you, south of you. They do not connect with those epic locations or partners. So that's a medium risk. I will say that, you know, they've, as I said before, they've made Cerner work for them. I think it would work well between you and them. It's a matter of whether it would work within a network, an ACO structure.
Just to jump in, the capital piece is a particular concern as you think about the competitive action issue. And so, again, using the example of one of the partners coming and dropping in, say, an ambulatory surgery center in your community, without financial backing, without the ability to respond to that type of activity, the island and the other hospitals would be constrained by whatever financial resources you have available or that you're able to generate yourselves to respond to that.
In a way, VM has prescribed a course of action that says the outcomes are going to be terrific. We're going to have very, very high performance. But what's happened is, in my opinion, the systems, that is the feds and who's the payers, haven't caught up with that idea yet. There's a gap between it, and so that they're not getting the money to be able to carry out what they think is the right answer. Am I off here a little bit?
You're not off. That's you know, it's their job now to go out to employers and payers and say, we're providing real value here, and we ought to get paid differently, and that has not yet occurred. That's what that's the road they want to go down, but it has not happened yet, and it's a very important bet that they're making.
But again, it's only on limited service areas. For example, back problems was one of them, and I think cardiac was the other one. Correct? I mean, those are their major pluses.
Yeah, they have focus areas. They want to extend this to a complete population management, but
they're not even close.
Well, they need to have more cooperation from the payers, as he says. It's just fact. I mean, I think the system they want to deploy is fabulous. I wouldn't take anything away from their vision. It's just that execution has run into the market. Right? Okay, so comparison to goals. We wanted to go back to those goals and quickly look at, does this proposal, does this potential partner enhance clinical services? Do they promote organizational sustainability, and do they prepare us for healthcare reform? Do they make us better in each of these three areas? From looking at the three of these, On enhancement of clinical services, we've talked about the fact that Peace Health focused on additional services in the region. They talked, I want to be clear, they did not say that every single service that every interlocal has will remain where it is and how it is. They said, look, we think that we can combine some things to Arlington or some things to Skagit or some things to Island as centers of excellence. So you do your burn program down in Arlington because they have an excellent burn program. Let's enhance that. You do your, we could have a level 2 neonatal intensive care unit at one place. Nobody has that right now in any of the 3 places. We could have what's called a Da Vinci robot that does very specific surgical procedures. And these are specific things they mentioned to provide an advanced level surgical technology, but only at one place. So that's how services might move around in their model. And that they would focus on extending their clinical services using UW clinical pathways. Providence did not talk a lot about adding services in the region. They did talk about rationalizing services with other regional locations. That means some consolidation. We couldn't tell and we couldn't ferret from their answers whether that also meant that services would move to Everett. And that was what the big concern was. And you can imagine specifically from Cascade, but I think generally from everybody, because we didn't get a definitiveness around the answer to that question. On VM, they said, as I said earlier, primary care clinics would be added to the region. Their specialty physicians would rotate. They did not talk specifically about service rationalization or development of new services, but they did focus on the fact that if we could up the quality and get to this, more standardized level of care, that we will benefit, and that will bring us additional revenues, and we'll be able to enhance those services. So that was the way they looked at it.
Let's talk a little bit about our physicians and what they've told us.
Okay.
And I don't want to. Oh, I'm sorry. You can't hear me. Sorry. I said let's talk a little bit about our physicians. I think we have an incredible group of physicians and nurses. And we've asked them, of these choices, what's your preference? And there was I guess a sort of a vote, I'm not sure, that they sort of together said that we put Peace Health at the very bottom of what we think is the best physician relationship, when we told this to Peace Health, but their response was, well, we haven't done the job we should to come down and talk and interact with your physicians, and our performances are very high, and therefore once we get this going, we're going to be rated much higher. But it's a little disturbing that our physicians have put Peace Health so low on the totem pole in terms of where they'd like to interact with the doctor. Jeff, is that what's your?
I mean that was the poll, but again, our model at Island Hospital has been take the best, leave the rest. And what I mean by that is the relationships that our physicians have enjoyed over the last decade or so have been developed or evolved in terms of when they send a patient to somewhere, how is the patient treated, what is the success of the treatment, how are they returned to us, how are we, since the patient lives in this community, how are we involved in their follow-up and things like that. And these different relationships, and they involve every one of these systems. They involve Peace Health, they involve the university, they involve Virginia Mason Children's, and everybody else. And one of the hardest things for us is to get away from that model, because we've used it for years. And there's some things we have in this community that nobody does better. And I think you know what they are. If you need a partial knee, we have 2 of the people in this community. They're some of the best west of the Mississippi. They're number 3 and 5 in the nation This is the nation. We did the first patient-specific partial knee replacement here west of the Mississippi. We would have done the first one in the country, but some guys in Minnesota beat us by 2 weeks. Okay? And, I mean, that's the problems we're grappling with is we have a model that, for example, if you come into our oncology clinic and you have a specific problem, you don't realize that your slides will go to the University of Washington, University of Michigan, MD Anderson, and they get reviewed. You don't get billed for that. That's something we do if there are any questions. And, for example, if there are any treatment things, if there's specific treatments for things, like my son had cancer when he was 10, the treatment was pretty straightforward. He got 2 drugs, dactynomycin, vincristine, he got 2,700 rads, and that cured his problem. That was a recipe taken off the thing that worked. Okay, a lot of the tumors, as they evolve, I mean, as we evolve, those recipes don't work for those. So those recipes are constantly being updated. We are connected with MD Anderson. We are connected with the University of Washington. If there's something we can't fix off the shelf up here, we will send you to a clinic that specifically handles these problems. And people just don't realize that this is a portal into a huge system. The problem lies now in the fact that what's coming down the road, because healthcare is so expensive, that we have to find a way to, survive. And how do we survive? We have to lower our costs. The medical equipment people kill us. I mean, for a pile of things for spine implementation, if I could show you these out of a hardware store that you'd pay maybe $20 for at Ace, it's $25,000. I mean, they're killing us. And the prosthetics and some of the oncology drugs. And the reason why bigger systems, are better if we can hold hands with them is we can get better pricing for these things. Better pricing for you, because we have to pay, a lot of these things we can't pass on the cost. We have to eat it. And you've seen our $4 million worth of uncompensated care and a host of other things. So what we're trying to do, A, is stay afloat, B, maintain the quality that we have maintained, and be leaders in some areas. And another example is there was a physician who flew up here from Reno for a specific procedure we did because they don't do it in Reno. That's the kind of stuff that, that I would like to, I mean, that's my dream.
All right.
Yeah, okay. I understand that, but
what would change if we affiliated, what you just described, what would change if we affiliated with one of these 3? What would change?
What we're looking for with one of these 3 is buying power, negotiations with the third-party payers, a bigger gorilla to deal with Medicare. For example, people don't know the reimbursement for Medicare on the East Coast is almost double what we get here. They have better people negotiating for them, and they have for 20, 30 years. We on the West Coast have always been better, faster, cheaper, and we've gotten clobbered for it. A bigger organization may be able to get us, because you see we operate on a 1% to 3% margin. And I invite you any Thursday to come look at any third Thursday of the month. We'll show you our budgets. We're not, despite some of the things you may think, we're not making a whole lot of money over there. And what I'm looking for in these things is who has the best buying power, who has the best negotiating power, who can provide the best care if I have to send somebody somewhere out of the community to get them the best care. And those are the things I'm looking for. And I put care at the top of that, and then down from that.
Thank you very much. Sorry, guys.
That's right. Did you have a question? Anybody else have a question? All right.
Well, I just have a little something to add, and that's one side of the scenario. The other side that you have to look at is what are we willing to give up? You don't get anything for nothing. So we need to know what we're willing to give up.
Okay. So, that was specific to what would happen to clinical services. This one is specific to organizational sustainability. Peace Health is looking through their scale to control costs, and that would be on support services consolidation and lowering your your purchasing costs, as I said. They're also looking to financially support the development of regional programs. So it's not just you generating your own capital for investment in your services. It's if we need that physician to come in and shore up that program, we're going to invest in that. If we need that building, we're going to do that. That's what they've committed to with their proposed $50 million. They would access, UW has already said you could access their branding. Some of the programs you talked about are UW affiliated. Those would be branded with your hospital. And Peace Health would also brand for other programs. So there would be that. Providence Swedish, their support services consolidation would be most impactful to you guys, meaning they have very significant cost savings through their very big support services organization, and they do purchasing power very well as well, as you can imagine on the scale that they have. As we said, organizational sustainability also relates to what the investment would be, and although I think if you affiliated with Providence Swedish, you would not go out of business, whether you'd get the capital to invest in enhancing services and remaining state-of-the-art is, as we said, a medium risk. And finally, they would provide their branding, Swedish branding up here. And finally, VM has not had experience with support services consolidation and did not, talk greatly about benefit, but they did say that there would be, they estimated there would be about half the benefit of what we saw with the other systems in looking at the other systems we can do actual costs of their support services because they have an organization with. Here they estimated it would be about half. We know that the capital would have to be generated locally with VM, and the branding for the interlocals would start on day one. Their initial proposal said it would be sort of evolved over time. They came back and said we would brand you as a VM facility from day one. Finally, preparation for healthcare reform. The Peace Health University of Washington Alliance has already begun to create or pay dividends. They have an ACO that has been accepted by the Boeing network, which is important. They also would have the underlying data would be provided through the EPIC system, and they would have an interoperability with that. Providence also has been accepted as a player in the Boeing network. They also have a health plan, so they have some assets with regard to attending to health care reform that others don't. They also have EPIC, and it would be installed rapidly, which would give you that underpinning for integrating healthcare services. And finally, Virginia Mason, they would prepare for healthcare reform mainly around clinically standardizing practices. We talked about that before. They are working to develop a high-value network. I think they can demonstrate value, but what they do not have is the participants in their network, and that's where they need to do some work. Okay? And Cerner would be installed, as you know. Okay, so that is the risks. That is the forecasts of what the goals, how they're met or not met. Any questions before we go on? Because the last part will be just a scorecard of various things.
Just a comment about the Peace Health, UW, and ACO. Vince, from you, comment about UW, that you could become we could become a part of the ACO with UW without being affiliated with Peace Health?
That is correct. We have been contacted by the University of Washington along with several other hospitals to become part of their ACO, which is in development right now. And again, that comes without any strings as to who we affiliate with. So one of the fears that we all had and still have is not being invited into these ACOs. And, the first one out of the chute doesn't really care who we are affiliating with. We're found to be a very vital part of that network, and hopefully that will continue.
Thank you.
Any other questions, comments? Okay. So we looked at, these are the final considerations. There's just a few pages on this, but basically on strategic vision, again, if you focus on clinical service development and financial wherewithal to execute your vision, PeaceHealth, UW had the top score. When you look at healthcare reform strategies, we've already talked about the fact that Providence has both the resources and the infrastructure and the scale to execute on healthcare reform, and Providence scored highest in that regard. When you look at financial considerations, we see very positive system and regional financial performance from PeaceHealth, and I think what set them apart and why they end up getting the top score is revenue opportunities, revenue enhancement opportunities from clinical service development. They were very explicit and much more upfront about investing in those services to generate new revenues. Now, Providence will get you, cost savings, but whether they're going to get you enhancement of revenue is another story. And VM just has limited financial resources, and most of those revenues will come from contracting, but that network is not realized right now. Future capital investment, we've talked about, it's committed from PeaceHealth. It was not committed from the other two, and looks to be generated from local capabilities and returns, so that would give that to PeaceHealth as well. Local and regional services, again, the focus on clinical services, regional capabilities in your local areas was the reason that PeaceHealth ended up getting that top score. When you move over to local governance, now the local governance, this is actually in their proposed affiliation. The district would retain control of operations, and joint ventures would be jointly governed. But what that means is you guys, the commissioners, would still have the same job that you do today in having the fiduciary and operating responsibility for the hospital. If there were joint venture operations, they would be joint ventures on things, programs, or services that would not have you give up the control of the hospital's operations. So those would be specific to those services. So on a control proposal, they lend you more control. That's why we said PeaceHealth here. Now, it depends on what you want, right? Because you relinquish control with both the PROV model and the VM model that's been proposed, okay? Having said that, the PeaceHealth model as proposed, the most recent one, doesn't go as far in the integration as the other two do. Affiliation structure, we talked about that, again, giving the nod to PeaceHealth, but because of that additional local control and the elimination of the statement of common value issues from the control and operation of the hospital. The benefits of the UW affiliation are also available to the interlocals, the benefits of being part of the ACO. PROV Swedish, certainly it's a very top-down organizational structure. You do have reserve powers, but they're limited, probably more constraining than any of the three. And finally, Virginia Mason, they would create a new company. They would do the leased hospital model, which means you would not have operational control of the hospital and would not have a majority of community members on the local board. So there would be quite a bit of a loss of control under the VM model. You would retain district reserve powers, just as we talked about earlier. Okay. Now that's, again, I need to stress that these entities have said we prefer this proposed level of integration. They have also said if you want a lower level of integration, we're open to that. Okay? But we're reflecting what they proposed. All right, finally, affiliation experience and interest. Both PeaceHealth and PROV Swedish have had a lot of affiliation experience. They've gone through this lots of times. The VM has limited experience. They've done it with Evergreen Health, but on a low-level affiliation. They've done it with both PACMed, which is a physician medical group, and with Group Health, but only in terms of utilization of their hospital, giving them basically an inpatient place to put their patients, so not on a fully integrated affiliation. On support services, we gave that to physician recruitment, this should actually say that under the model that's proposed, we would give this to Virginia Mason, not PH and UW. This reflects earlier when Peace Health had a stronger model proposed. But under their current proposal, it's more comprehensive with VM. They would be all in terms of being able to provide recruiting resources. Not to say that Peace Health wouldn't support recruiting and, as it says here, have a rotation pool to cover physician shortages, et cetera, but we think that VM has a stronger comprehensive approach. Support services, this is strongest on Providence, and we've talked about that. And information systems, it's also strongest in Providence, and we've talked about that. Other factors, branding, we thought that each of them would bring a different brand to the table. The UW brand is a very significant brand. The Swedish branding is also well thought of, and VM has a strong national brand and quality. So we thought that was kind of in the eye of the beholder, and so we did not say that there was a top score on that. And certainly on faith-based issues, there are no faith-based issues with VM, and there's just no way that you can give it to the other two because it would come with concerns. So that was the sort of final scoring, if you will, final considerations related to how we looked at this whole compendium of information and this whole process that we've gone through that has taken us a couple hours to go through. Those were the final considerations around how everything scored itself out. So questions or comments?
Which one of these organizations provides the best health care by any metric? Well,
the thing is, if you talk to all three of them, they would tell you that they do. And, there's not a clear-cut winner. There's some, Peace Health has one of the best cardiac programs in the nation in Bellingham. UW has some tertiary and quaternary services that are also world-class. And VM's been recognized nationally for its overall quality and for its approach to coordinated health care. So I don't think I could answer that without being subjective, and it's not what this process is supposed to be about.
I ask that question more for the benefit of the audience than for...
Yeah. But most of the focus is on the business model, although we do talk a little bit of... I see not a lot of doctor stuff in here in terms of how we're going to have our docs work with whomever we affiliate with. That's not necessarily different than anything else we do, because the sort of programs we try to put together and try to engage the docs, we find it difficult to bring them in until we make a decision. And then they ask, what the heck are you doing? That's the nature of the beast that we're dealing with. But, we don't have a hospital without a doctor.
Yeah, sure.
Well, the way I would respond to that is you're correct in the fact that there aren't any specific strategies for how do we integrate the physicians between the suitor and our interlocal facilities. But there's a lot that pertains to doctors in here. If I could just say that for a minute. One is recruiting and retention, and what's the approach to recruiting and retention. The second is for the UW, the residency programs and the training programs and research related to that. For instance, where is there a possibility that we can expand these clinical services to include clinical trials, to include additional residency programs? Those are important things that relate to doctors. And finally, service expansion. Is the service that I'm involved in, if I'm a neurologist or I'm an oncologist or I'm a cardiologist, is that service going to wane or is it going to be expanded? And I think a lot of that pertains to the lifeblood of your hospitals, but also the lifeblood of your physicians. They want to be part of something that's growing, expanding, that's dynamic. And so I think each of these organizations has given its own spin on how they would deal with those three things, and it's different. VM is going to focus not so much on huge expansion, but they're going to focus on, kind of implementing their lean and production systems and kind of trying to get to a very, very high standard of quality and care delivery. Peace Health has focused a lot on service expansion and the UW connection. So those are very germane. The one that probably talked least about it was the Prov Swedish proposal. They talked more about the efficiency of their overall organization, their business model, that sort of thing. But they did talk about the fact that their doctors have some significant relationships with your doctors, and the referral relationships they would work on enhancing, and we would need to know a lot more about what they had in mind, because that part was fairly vague, but that's what they focused on. So I think there was a lot that will impact doctors. They just didn't speak directly to how they were going to integrate the doctors.
Well, let's talk a little bit about what's next. Can we do that?
Yeah.
Because we have committed to do something next Thursday with our other partners in interlocal. And what are our options? What are our options for next? We've got this data, and the three of these, ladies and gentlemen, haven't had a chance to really digest. I mean, since I went through this whole thing, I have a better understanding of all this stuff. But so they're wondering, what do I do with this information? What are the options that are in front of us now?
Okay, I think I would put it this way: in terms of logistics, there's a combined board meeting next week. It is the intent to select a preferred partner at that point in time. Okay, but the nuance of what we're saying is the partner should be selected based on which of them best gives you the chance to achieve those three things that we saw as goals earlier in this presentation: enhancing clinical service capability, preparing for healthcare reform, and promoting your long-term sustainability. Those three things. Now that's the partner, right? Okay, so who best gives you the opportunity to do that? That's where you guys have to look at everything we've talked about and say, okay, the best partner for the future is X. Now after that, and it's not in this presentation, but after that what happens is you sign a letter of intent, and the intent is that all three of the interlocals will sign a letter of intent with the same partner. Okay? Why? Because I think, as Matt stated earlier, there's the capability of synergies across the region that are very great with one partner, and they get very diminished by everybody having a different partner. And in fact, many of these have told us that they are not really interested in piecemealing the partnerships. They'd rather do one partner with all three partnerships for the same reasons. Okay, so if that happens, you select one partner, you sign a letter of intent, then the sort of heavy lifting comes in, where each, as Matt showed you in that graphic, there's going to be an affiliation agreement with each interlocal. It's not going to be one vanilla agreement that crosses across three interlocals. And so this is where I was referring when I said about 10 minutes ago, they will do any level of affiliation that the interlocals want to do. So say you pick X partner, somebody of the three could negotiate a very high affiliation, an all-in, lease the hospital to them, reserve powers, the kind of thing we said before. Somebody else could take an option that was centered around joint ventures and didn't transfer governance and that kind of thing. And somebody else could go for a very low level of affiliation that didn't get into IT partnerships and and got into more of what I would categorize as sort of the evergreen VM relationship, where we're doing some service coordination and potentially getting together on some support services, but just kind of a sort of a dance before we get married kind of a thing. And all of that would be plausible with one partner having 3 separate agreements that were very different in tone and in depth. Okay? So I just want to be clear that next week is about picking that partner that everybody thinks will best answer those 3 goals. And after that, the negotiation of the specific agreement for Island takes on its own persona and its own, depth or not in terms of the level of affiliation, separate from what Cascade might do or what Skagit might do.
What happens if our 2 partners select suitor A, and for whatever reason we select suitor B or something? What happens to the ability to carry out the objectives, the goals that we're trying to do?
Right. Obviously, I think it's, anytime you fragment the affiliation, it diminishes it. So there's 2 questions that come out of that, and I just want to be very honest. One is, would the partner that you picked, if it was different than the partner that the other 2 picked, would they be interested in affiliating with Island? That's their call at that point,
alone,
right?
Island alone.
And so that's a vulnerability that we just have to be honest about. And I'm not just focusing on Island. I think that same dynamic is true among any of the 3 partners. But then what would happen if it were accepted by that partner? Then you would negotiate your own agreement. But whereas you might have some collective support infrastructure between the 3 interlocals if you chose one partner, or you might choose to consolidate services into one center of excellence like we talked about earlier. Obviously none of that's going to happen if you guys are doing something with somebody else. So the synergies are reduced in terms of what you could do within the region. Contracting would be different, obviously, because you would contract with one partner, they would contract with another. So, it just, as I said, the fragmentation diminishes the overall financial and clinical potential.
I think it's also fair to say that the flexibility of the partner, if there was one hospital selected a different partner, that the flexibility in terms of the structure, is it high, is it low, et cetera, would be less in that scenario. It would be more driven by the interest of the partner, if they were interested in low or if they were interested in high.
I would concur. I mean, I agree. I would think they would probably say, well, we only want you if you're all in at that point.
What will be the structure of that meeting? Will we have a chance to voice certain opinions in the beginning, and then how is the vote structured?
Oh, you mean at the meeting next week?
Like a double secret ballot, or what?
Yeah, the room goes dark, and
yeah.
No, I mean there's some front end stage setting, if you will, and then each of the and there's comments from the commissioners, that sort of thing, and each of the boards then take an individual vote on what partner they would select.
When you say individual votes, I mean
individual boards. I don't mean individual people. I mean, your board would vote for what Island.
Let's ask Don Black, our
Don Black,
can you tell us how this would work?
To discuss the structure, because we're concerned about influence by majorities.
Oh, I see.
What I can say is that it's going to be an interesting process, and we're trying to work out what the best part of that process is. As you can imagine, there's definitely the influence, who goes first, who goes second issue, but you also have the issue of, is there some sort of panel of votes on, are we going to vote on all three and whoever gets the most votes, and then we're going to try and pick, make some indication on whether it's high or low. In order to come up with a setting that's going to work for all three of the interlocal partners at the joint meeting, I think that one of the things that could be very helpful for Island Hospital and for you as the Board of Commissioners is to discuss a little bit here tonight, now that you've been presented with all of this information, how you see amongst yourselves the pros and the cons of the various potential partners, so that at least as the four of you sitting here tonight have some feeling for what the others are thinking before you go to the meeting next week. Because I think if that exchange doesn't happen, it will be even more difficult to come up with a process that will be complete enough, but also direct enough to actually make a selection.
Okay, I'll make a comment. This comes from our Medical Executive Committee, and in their letter to us, I'll wait till they're done because I want them to address this issue. No, that's all right. I just wanted to make a comment. In the Medical Executive Committee wrote a letter to us, and they actually agreed on a document, which we thought was wonderful. And we can thank Dr. Harrison for that, our Chief of Staff. But they used the term they're interested in corroborating, and corroboration, not affiliation. So we're dealing with that. We want to be certain that our doctors are able to send patients for continuum of care to other hospitals in our region. We want to be able to maintain that ability, and our doctors are very interested in being able to do that too. So that's just a comment leading into our discussion about how we feel about all this. This is a lot to absorb, realizing we have not, all of us, haven't had all this information available to us. This is a huge responsibility.
I can tell you,
we take it very seriously.
I can tell you in response to that specific concern, we asked that specifically of all of these suitors, will referrals be restricted? And they said no. You can refer to hospitals or doctors outside of our system. So we cannot tell you that you have to refer to that doctor or that hospital. We can't restrict you from that, and so that will not be a restriction in place, from a formal process. They have to discern whether they think that's acceptable or not, but that's a question we specifically asked.
Well, let's say that we're in a real conundrum here, and we just can't decide on one of these three by next Thursday. Mm-hmm. How devastating would it be to the interlocal situation if we said, look, we would like to continue to work with you. We have these relationships that go on, and we will step back a little bit and really look at what works for us better. That's not the right word, but I mean would be better for us. Yeah. Would the interlocal fall apart?
No. In specific, if you're assuming that the other two made a decision that was the same decision, on the same partner, and you decided you needed more time or something like that, no, I don't think that's devastating. You have to do what's best for your community. You have to make sure that you are, committed to the decision. Although, as I say, it's only a letter of intent and it's not binding, and the real decision comes at the end of that period when you're asked to sign definitive agreements. But having said that, in my opinion, it is not devastating to the interlocal relationship if you said, we need more time or whatever it is that you happen to say. If you said we're going to be on the sidelines for a while, year or two or something like that. I also don't think that that's devastating to the partnership. I think it's something where you might miss out on some front-end synergies. I won't lie to you, but again, I can't tell you what's best for your communities. We're just trying to give you the information to make the most informed decision, but I can't see either of those scenarios sort of ruining the relationship or diminishing the partnership. Where I spoke to in your last question was specifically if you pick different partners. Now that's a different situation that I do think creates competitive and non-cooperative issues.
Yeah. Vince, I'd like to hear your comment on that. Would you share that with us, or choose not to?
On the issue of
what if we take a step back, but continue to work towards some sort of affiliation or collaboration or sort of thing?
Well, I agree completely with Dan that I don't think that would disrupt anything that we have going with the interlocals. And in fact, I think it also offers us, I think, a lot more flexibility in many ways to continue some of the programs that we are already enjoying with perhaps other people that may not be selected. For example, we have the Swedish telestroke program, which works extraordinarily well. Should everybody decide to go with VM, programs like that would not be renewed. We would have to go with the VM telestroke program, which I'm not even sure they have. So having a flexibility to continue to really choose the best of breed programs from around the area has thus far served us pretty well. Now, it hasn't gotten us the kind of advantages that you might have seen up there in terms of, $2 million on the low end or whatever, but we still have the ability to enter purchasing programs from other organizations, and we're currently looking at those sorts of things. I just continue to hearken back to the very inception of this, when we all were told and we all read in the materials that one of the chief things that you look for in these affiliations is the culture. Would your culture fit in with the partner? And even as we looked earlier and we saw some rather staggering numbers about a cultural fit with some of these organizations, I'll tell you, they weren't mine, because I have absolutely no idea how our culture at Island Hospital would fit into a large organization, much less one that has religious values to it. Our board voted 3-2 to honor the Death with Dignity program, which was one of the few hospitals in the state of Washington honoring that within their walls. So it's hard to imagine how our culture would fit into something like that, because we would have to change that. In addition, the board, administration, our medical staff, and our employees have worked extraordinarily hard to come up with patient satisfaction scores which outstrip any of those people that you see up there, bar a few. Our consumer reports have been stellar. Our medical staff satisfaction is at an 89%, unheard of in the United States, and our employee satisfaction is the envy of other administrators. We have to make sure that we not only preserve that, but we want to improve on that. And I think that's going to be a huge struggle should we, A, go deep with another organization, and just how we work with another organization. Our doctors have told you and I that they came here because this is the kind of organization they want to work with. They didn't put on a UW lab coat. They could have, but they chose not to, because they want to come to this kind of community. We need to really think through all of that. We're not in dire emergency straits at this point in time. If the board said, now's not the right time, administration would work with, maybe some wonderful consultants to lay out a plan for 3 to 5 years on how we continue to work through this while things fall into place. There's an awful lot of stuff out there that is really distracting us from what we really should be doing, and that is delivering the best patient care we possibly can.
But
Should say and, never but. But is a bad word.
Okay.
And.
Okay. The way I'm reading this tonight, and the reason I was interested in the structure of the meeting, let us just say hypothetically that Skagit Valley goes with Peace Health and Cascade goes with Peace Health. We are now an island in the middle of hostile territory. Now what do we do?
I don't look at it that way. Let me comment. I look at it as our patients now have a choice. They have a choice. I don't look at it that way at all. I know we're surrounded by hostiles, but I look at it as we have a choice. And I truly believe that if we are strong, continue to offer all of the issues that we would have trouble offering, that we're talking about ERDs, we offer those legal issues at Island Hospital, we need to continue to support it. And I believe that the community is smart enough to realize that our cancer center offers everything that cancer centers do in Seattle. A number of our departments at our hospital offer services and treatment that are equal to and better than services in Seattle. I'm hoping that our community will think twice about leaving this community to get services elsewhere if we make the decision to stay independent or provide a choice for people in our community. I hope they do.
Lynn, do you want
You've got a comment?
Yes, I really would consider it a privilege to be able to comment on this, because that's what I've basically been bringing up all night are what are we willing to give up? What services are we willing to give up? Well, I'm not willing to give up the services that we have through Island Hospital, and I'm talking about the RDs. And so that's pretty much what I've been talking about all night.
Well, it's 20 minutes till 8. We said the meeting would go to 7. Help me with this structure. What more we have to do, Dan, this evening?
There's no more that you have to do. We presented the data. This is the next steps is the last slide. So unless there are questions or comments, it's your show.
Dan, how will we find out about the structure of the meeting on Thursday night? In other words, the voting structure that Don alluded to.
As Don said, it's still in development between the lawyers are talking, and I'm sure that will come out within the next day or so, probably tomorrow. But they have to basically agree on that format. So there's meetings to be held.
How will we find that out?
I believe on Monday
I don't
we
know
have it scheduled for the management meeting together with several attorneys to come up with the structure of how this gets done, and then we will communicate that to our boards exactly how that's going to work.
Okay, that becomes open public information.
Sure.
So how do we communicate that to the community so they'll know in advance of that meeting? We just put it in the paper?
Oh yeah, it'll be it'll be another public meeting, and they can come.
Raise your hand over there because you're taking notes.
And hear the boards vote. Now, exactly, are they voting on, as Don suggested, a series of items, or are they voting on one recommendation by the Joint Steering Committee of the board, or whether they're going to be voting on one recommendation from the individual Joint Steering Committees? We need to flesh that out. But you'll know exactly how we're going to do it. And Don, you want to add anything to that?
Well, that's right. We'll try to do it on Monday when the administrators get together and those are the various options. But because it's a joint meeting, but it's really 3 meetings. It's each of the individual boards will be meeting, and each of the boards will be acting as an individual board. So there'll need to be a special meeting notice that goes into the paper Tuesday or late Monday after the structure is determined.
Have we decided on the shape of the table? Sorry for the Vietnam reference.
Are there any other points or comments from the commissioners? Well, I'd like to bring this meeting to a close, if that works for you, Vince. And,
absolutely.
So at 20 minutes to 8, the working board will close for this evening. And thank you, everybody who stayed to this rather long but interesting time.